Good morning, everyone. Happy New Year. Hope everyone is staying healthy. Today, I'll be speaking about the guidelines for the diagnosis for CAD. Are they nice, acceptable, or just plain eccentric? And I'll be leading you through this foray into the guidelines through the lens of a cardiac imaging fellow. These are the objectives I'll be covering today. Cardiovascular disease remains a leading cause of death, morbidity, and health economic burden worldwide. Currently accounts for more than 17.6 million deaths each year. This number is projected to exceed 23.6 million by the year 2030. This somber statistic is equally applicable in Canada, where this slide shows that the prevalence of cardiovascular disease, shown in the light blue color, is only continuing to grow as our population continues to age. As we all know from experience, chest pain itself is one of the most common reasons for emergency department visits. In the emergency department setting, despite the deluge of patients coming in with chest pain, only 15 to 25% of these have an underlying diagnosis of ACS. And additionally, the diagnosis of ACS is missed in about 2% of patients. Now, regardless of age demographic, the etiology of chest pain is overwhelmingly non-cardiac. Given the prevalence of patients presenting with a non-cardiac etiology of their presenting chest pain, we need methods to be able to differentiate true cardiac chest pain from non-cardiac chest pain. And yes, returning to our foundations to take a thorough history and actually speak with our patients has good clinical utility here. This is from JAMA in 2005 and outlines how various historical elements affect the pretest probability for CAD. And this is from the newest 2021 ACC guidelines, which again continue to recognize the importance of the history in our patients with chest pain. But if the diagnosis of ACS or cardiac chest pain is not obvious based on the history, EKG, and possibly biomarkers, then unfortunately differentiating cardiac from non-cardiac chest pain is more nuanced and requires further investigation. Ultimately, we need to determine whether a patient has CAD or not, and this typically requires further diagnostic testing. Right now, we're moving towards value-based medicine. We don't have infinite resources, and we have to be prudent in what we do use. We cannot order coronary angiograms for every patient presenting with chest pain. With so many options for risk stratification tools, we need some method to decide on the right testing for our patient. To start off our discussion this morning, let's rewind to 2014. I think this is a good time point to begin our discussion, and we'll start our journey with a foray into the 2014 Canadian guidelines for the diagnosis and management of stable ischemic heart disease. Clearly, I'll focus my discussion this morning on the diagnosis portion of the guidelines. This document provided us early guidance for selection of an initial non-invasive test for diagnosing suspected CAD in routine practice settings. A key component of selecting patients for risk stratification in the CCS guidelines boils down to determining a patient's pretest probability of CAD. It warms the cockles of my epidemiology-trained heart to see Bayesian theory creeping into pop culture, and yes, it plays a prominent role in patient selection for diagnostic testing. Essentially, in Bayesian theory, the probability of an event prior to receiving new data influences our posterior probability, i.e. the probability of the event in the light of the new data, or in this case, our diagnostic testing results. Now, this concept is important, both in terms of selecting which patients we should be doing testing on, but also on which tests we should be selecting. Bayesian theory supports the premise that diagnostic testing has less effect on final diagnosis when pretest probability is at the extreme, either less than 10 to 15% or greater than 85 to 90%. When the likelihood of CAD is high, a large number of patients need to be studied to identify the few patients that do not have disease, and a negative test result can seldom rule out the presence of obstructive CAD, i.e. the negative predictive value is low. Conversely, when the pretest probability is low, a negative test can rule out the disease, but the lower the pretest, the higher the likelihood of a false positive test. In patients at the extreme ends of the probability range, it's therefore reasonable to refrain from diagnostic testing and assume that the patient does or does not have obstructive CAD based on clinical evaluation alone. So a key component to Bayesian logic is calculating prior probability, and the Canadian guidelines make use of this concept. As per the 2014 Canadian guidelines, the first step of our clinical assessment is to determine if patients have typical, atypical, or non-anginal chest pain. This assists in determining a patient's pretest probability of coronary artery disease. Once we have characterized the patient's chest pain, the Canadian guidelines make use of the Diamond-Forrester and CAS data to use this information to determine a patient's pretest probability of CAD. Now, it should be noted that the data for this table was derived from a database of CAF patients, so inherently these patients are higher risk, and therefore the baseline prevalence of disease is likely skewed upwards compared to what we're seeing on an outpatient cardiology referral basis. However, this at least gives us a framework to work from in order to determine a pretest probability for our patients. In patients that have either 2 or 3 anginal features, or even patients with 1 out of 3 anginal features, but who are males over the age of 40, females over the age of 60, or are patients who have severe or multiple risk factors, then non-invasive testing is recommended. Although they provide clear flow diagrams here regarding test selection, they are explicit in stating that testing options may be modified where expertise and access to various imaging modalities exists. With respect to guidance regarding test selection, the first branch in the road is to look to see if patients are expected to be able to augment their heart rate to 85% of their max predicted, or if they have any contraindications to exercise. If they can augment their heart rate and they have no contraindications, then the CCS states that they would be ideal candidates for stress ECG or stress imaging. Next, you look to see if the patient has a normal or abnormal baseline EKG. With a normal EKG, the CCS recommends stress testing. If their EKG is abnormal, then the patient should have some form of imaging testing. If there's an abnormal EKG without a left bundle or paced rhythm, then either exercise echo or myocardial perfusion imaging are the tests of choice. If there is a left bundle or paced rhythm, then vasodilator perfusion imaging is the test of choice. Now, flipping over to the other side of the flow chart here, if the patient's unable to exercise, you again look at the EKG for abnormalities. With a normal EKG, you can do either dobutamine or vasodilator echo or vasodilator perfusion imaging. I'll draw your attention now to the bottom of the flowchart, to cardiac CT in the Canadian guidelines, which were really relegated to the proverbial back of the line. In all honesty, from the Canadian perspective, only patients that cannot exercise, have an abnormal EKG with a left bundle, or paced rhythm should be getting referred for cardiac CT. So in the 2014 CCS guidelines, CT was really left on the outside, looking in. And on that note, we'll now transition to the new and improved NICE guidelines, which came out in 2016. And these were actually a major momentum shift. In 2010, the original NICE guidelines recommended that the choice of investigation be determined by the pretest probability. The document then recommended that patients with a pretest probability of less than 10% should actually not undergo cardiac investigation. For patients with a risk between 10 to 30%, they recommended sending for calcium scoring. A 0 calcium score was taken as confirmation of very low likelihood of CAD, and no further investigation was needed. If the calcium score was above 0, a CT coronary angiogram was recommended. Patients with an intermediate risk score between 30 to 60% were recommended to have functional imaging, such as myocardial perfusion imaging, stress echo, or stress CMR. Patients with a high risk between 60 to 90% were recommended to directly undergo invasive coronary angiography. And finally, patients with a risk above 90% were assumed to have CAD without any need for further testing. The NICE guideline update in 2016 made 3 key changes to the 2010 version. The first is a recommendation to do away with the pretest probability calculation. They do still recommend assessing a patient's symptoms and looking at whether they're typical, atypical, or non-cardiac. The second change in the guideline is that a 0 calcium score is no longer used to rule out CAD in patients with low pretest probability. And thirdly, and perhaps most radically, NICE now recommended that all patients with new onset chest pain with either atypical or typical anginal features, and even those with non-cardiac chest pain but with an abnormal baseline ECG, should be first investigated with CT coronary angiography. Thus, according to NICE, functional imaging tests were now reserved for the assessment of patients with chest pain symptoms who are known to have CAD, and for patients where the CT coronary angiogram has been non-diagnostic or has shown CAD of uncertain significance. So while the guidelines prior to NICE suggested pretest probability calculation prior to assigning the most appropriate imaging modality, the modified NICE guidelines discarded this and suggested cardiac CT as the first-line diagnostic study. Nuclear perfusion imaging was relegated to one of the second-line studies, which were to be referred for depending on the results of the cardiac CT. This drastic change was based on the results of a number of clinical trials, including Avinci, Scott Hart, Promise, and Platform. And these trials all demonstrated increased accuracy, diagnostic certainty, and less unnecessary invasive coronary angiography for cardiac CT in comparison with functional studies. The NICE guidelines were obviously not without controversy, and some even asked, can cardiac CT substitute nuclear perfusion imaging? The value of cardiac CT seems to be most prominent as a gatekeeper for preventing invasive coronary angiograms with no obstructive CAD. Based on its high negative predictive value for detecting coronary plaques, including non-obstructive plaques, cardiac CT can be an excellent choice when a negative invasive coronary angiogram is a major concern, for example, in patients with low to intermediate pretest probabilities. But image quality in cardiac CT can become a major issue in study interpretation. There are several important factors that affect image quality in cardiac CT, but a big one that we see quite frequently is coronary calcification. On one side of the coin, coronary calcification carries significant prognostic information. This paper from Tay et al. Highlights this point. In this paper, they reviewed 934 consecutive patients who received coronary artery calcium scoring and CT coronary angiography. Patients were grouped based on their calcium score into groups of 0, minimal with scores of 0 to 10, mild with scores of 10 to 100, moderate with scores of 1 to 400, and excessive with scores over 400. There were no significant differences between the 0 and minimal groups, but the mild, moderate, and excessive groups all showed correlations with significant coronary stenosis, i.e., as the calcium score increased, so did the amount of coronary stenoses. Unfortunately, the image quality of cardiac CT can also be highly compromised in the presence of heavy calcification, which is, and which I just showed you as Tay demonstrated, associated with a higher prevalence of significant coronary stenosis and higher overall global CAD risk. Studies have shown decreasing diagnostic accuracy, especially specificity, of cardiac CT with heavier calcification. Thus, when considering this, it's not appropriate to conclude that cardiac CT can be a perfect substitute for functional imaging, including nuclear perfusion imaging. So now that we've covered the NICE guidelines and some of the associated controversial topics with that set of guidelines, let's take our journey over now to mainland Europe. The ESC guidelines are fairly recent and were released in 2019, and the guidelines break the recommendations for diagnosis of CAD into 6 steps. Step 1 is to assess and perform clinical evaluations. As we all know, a careful history is the cornerstone of the diagnosis of angina. However, again, if the diagnosis of ACS is not obvious based on the history, EKG, and possibly biomarkers, then differentiating cardiac from non-cardiac etiologies requires further investigation. For step 2, before any testing is considered, one must assess the patient's general health, comorbidities, and quality of life. If revascularization is unlikely to be an acceptable option, further testing may be reduced to a clinically indicated minimum. An appropriate therapy can be instituted, which may include a trial of anti-anginal medications, even if a diagnosis of CAD has not been fully demonstrated. Non-invasive functional imaging for ischemia may be an option if there's a need to verify the diagnosis in this case. In step 3, baseline testing should be completed, including a resting ECG, biochem panel, chest X-ray in selected patients, and a baseline echo. For intermediate risk patients with acute chest pain, transthoracic echocardiography is recommended as a rapid bedside test to establish baseline ventricular function, valvular function, evaluate for wall motion abnormalities, and to assess for pericardial effusions. A baseline ECG and possibly chest X-ray are also recommended, not surprisingly. All right, so step 4 is bringing back our old friend, the pretest probability. And the ESC guidelines endorse binning patients into categories of typical, atypical, or non-anginal chest pains. And based on their symptomology, we can again go back to calculating a pretest probability for the patient. I'll point out, though, that this table differs from the data derived from the Diamond, Forrester, and CAS data. Notably, the prevalence of disease for a given constellation of age, sex, and nature of symptoms is lower for each respective category than in the Diamond, Forrester, and CAS data. In the last several years, several studies have indicated that the prevalence of obstructive CAD, of obstructive disease amongst patients with suspected CAD, is lower than what is provided in the Diamond, Forrester, and CAS data. This study from Victor Chung et al. In 2011 looked at the accuracy in the traditional Diamond, Forrester pretest probability calculation in determining CAD. They identified over 14,000 consecutive patients with suspected CAD who underwent cardiac CT angiography. They calculated pretest probability based on the Diamond, Forrester, CAS plot, and then correlated this with the results of the CT angiogram. You can see that for atypical angina, the expected incidence of obstructive CAD was much higher, shown in the gray bars, than what was actually observed in the black bars. This is the same for typical anginal symptoms as well. I think this is an important point to emphasize. Overestimation of pretest probability is an important contributory factor to a low diagnostic yield of non-invasive and invasive testing. Thus, the updated guidelines have taken this into account, and the pretest probability based on symptomology is lower than what is seen in the Diamond, Forrester plot. The ESC guidelines also recognize that we don't operate in a clinical vacuum. Clinical models that incorporate other information, like risk factors for CAD, resting ECG changes, or coronary calcification, have improved the identification of patients with obstructive CAD compared with using just age, sex, and symptoms alone. Therefore, the presence of cardiovascular risk factors, presence of coronary artery calcium score, or even baseline EKG changes can be used as modifiers of the pretest probability estimate to help improve and refine our pretest estimations of obstructive CAD. Another important point is that the table now also includes patients presenting with dyspnea as their main symptom. All right, so we now come to the meat of the matter, ordering diagnostic testing. The ESC guidelines state that for patients at the extreme ends of the probability range, it's reasonable to refrain from diagnostic testing and assume that the patient does or does not have obstructive CAD based on clinical evaluation alone. In addition, factors such as preference, availability, and local expertise should be weighed in the decision. At low intermediate pretest probabilities, the ESC recommends coronary CT angiography as the test of choice. For moderate to high pretest probabilities, they recommend ischemia testing. And for very high pretest probability, invasive angiography is recommended. I'll point out a few specific highlights from these guidelines. The ESC gives a Class 1 recommendation for either functional imaging or cardiac CT as the initial test to diagnose CAD. And it's recommended to make the decision regarding modality based on several factors, including the clinical likelihood of CAD, patient characteristics that influence test performance, local expertise, and local availability. Performing cardiac CT is a Class 3 recommendation in the presence of extensive coronary calcium, irregular heart rate, significant obesity, inability to cooperate with breath hold commands, or any other conditions which could compromise image quality. Also, we do not use coronary artery calcium scoring to identify individuals with obstructive CAD. And this brings us to the highlight of the show, the 2021 ACC chest pain guidelines. These were released very recently, published November 30th, 2021. The first thing to note is that they have fundamentally changed how we describe chest pain. Gone are the days of describing symptoms as typical, atypical, and non-cardiac, and the new lingo is now cardiac, possibly cardiac, and non-cardiac. The ACC guidelines also bring in a modified form of the pretest probability. The darker green and orange shaded regions denote the groups in which non-invasive testing is most beneficial, i.e. patients with a pretest probability greater than 15%. The light green shaded regions denote the groups with pretest probability less than 15%, where testing for diagnosis can be considered based on clinical judgment. If coronary artery calcium scoring is available, it can also be used to estimate the pretest probability, which you can see in the bottom bar there. The next thing to note is that they split patients into acute versus chronic chest pain. Patients with acute coronary syndromes are brought for invasive coronary angiography. For patients without ACS, regardless of the acuity, imaging is reserved for intermediate high-risk patients. The choice of imaging depends on the clinical question of importance, to either A, ascertain the diagnosis of CAD and define coronary anatomy, or B, assess ischemia severity amongst patients with an expected higher likelihood of ischemia with an abnormal resting ECG or those incapable of performing maximal exercise. All right, so let's swing over to this side. And again, in the new guidelines, we think of things as either acute or stable chest pain. So let's start by focusing on the acute chest pain patients for a moment. Before we begin, I again just want to make it clear that these are not my personal recommendations as we walk through here. I'm simply walking through what the guidelines have outlined. And with that, let's start our focus on the acute chest pain side for a minute. In patients presenting with acute chest pain after our history, physical, and EKG, if we think that this could possibly be an acute coronary syndrome, then we need to get cardiac biomarkers and use a clinical decision pathway to risk stratify the patient. If the patient's high risk, then invasive angiography is the way to go. If the patient is deemed to be low risk, then it's recommended that no further testing be pursued and the patient be discharged. Patients in the intermediate category are the group that can benefit from further diagnostic testing. And this is where I'll go into a little more detail regarding test selection. This flow diagram outlines the diagnostic approach to patients presenting with acute chest pain who do not have a known history of CAD. In this group, the first step is to look to see if patients have had prior testing. If they have, they fall down this left side of the flow diagram. If their recent testing was negative, you can safely discharge them. If they had a moderate to severely abnormal test within the past year, it's recommended to send them for angiography. And finally, if they had a prior inconclusive or mildly abnormal test, then it's recommended to consider cardiac CT. If they have non-obstructive disease on their CT angiography, you can consider discharge. If they have an inconclusive test, it's recommended to pursue FFRCT or stress testing. If this is negative, make sure they're on optimal medical therapy and they can then be discharged. And if it's positive, refer for CAD. If the initial CT angiography is positive, i.e. it shows an obstructive lesion, then you have several options. You can risk stratify with FFRCT or stress testing. You can optimize therapy and discharge the patient, or if you feel they're higher risk, you can refer for invasive coronary angiography. Now we flip to the other side of the flowchart for patients with no prior testing. This falls down the right side of the flow diagram. Here you can do either stress testing or CT angiography. And note they lump exercise ECG, stress MRI, stress echo, stress PET, and stress SPECT all under the one umbrella of stress testing and all garner Class 1 recommendation. Ultimately, they recommend that test choice should be guided by local availability and local expertise. With a negative test, the patient can be discharged. With a positive stress test, they recommend invasive coronary angiography. With an inconclusive test, they recommend getting a cardiac CT. If a cardiac CT is done, a patient with non-obstructive disease can be discharged. A patient with obstructive CAD that's high risk or with frequent angina should be sent for angiogram. A patient with an inconclusive test or an obstructive lesion that's not high risk can either be managed medically and discharged or can be sent for either FFRCT or stress testing. And if this further testing is high risk, then the patient can be referred for invasive coronary angiography. And if it's not high risk, the patient can be optimized and discharged. This flow diagram now outlines the diagnostic approach to patients presenting with acute chest pain who have a known history of CAD. In these patients, the first step is to look to see how severe their known disease is. If they have a known lesion that's over 50%, we go down the right side of this flow diagram. There's a Class 1 option to defer testing and intensify their medication regimen. Otherwise, there's a 2A recommendation for functional testing with either stress CMR, stress echo, PET, or SPECT. If they have a less than 50% stenosis, we go down the left of this diagram. Again, there's a Class 1 option to defer testing and intensify their medication regimen, and otherwise there's a 2A recommendation for either cardiac CT or stress testing. In patients that have a CT done, the important point is to look to see whether their disease remains non-obstructive or if it's progressed. If it's non-obstructive, you can optimize and discharge the patient, And if it's progressed, there's a 2A recommendation for FFRCT or stress testing to determine the functional significance of the lesion. Here, you're looking for FFRCT values less than 0.8 or moderate to severe ischemia on functional testing. If they don't have those features, you can again discharge them. Otherwise, it's refer for invasive angiography. If the decision is made to do stress testing initially, we're looking for normal versus abnormal functional testing. Patients with normal testing can be discharged, and patients with abnormal functional imaging tests can be referred for invasive coronary angiography. A few key takeaway points. Firstly, for intermediate patients with acute chest pain and known non-obstructive CAD, cardiac CT angiography can be useful to determine progression of underlying atherosclerotic plaque and garners a 2A recommendation. They also give functional imaging a 2A recommendation for these patients. Next, for intermediate patients with acute chest pain and no known history of CAD, you can use either exercise ECG, stress echo, stress nuke, or stress CMR for the diagnosis of CAD. These all garner a Class 1 recommendation. For intermediate patients with acute chest pain and no known CAD who had a prior inconclusive test, it's reasonable to do CT angiography. And likewise, for intermediate patients with acute chest pain with no known history of CAD who had a prior inconclusive CT test, it's reasonable to get functional imaging with a nuclear perfusion scan, stress echo, or stress CMR. All right, and now let's move on to stable chest pain. And first up in the stable chest pain algorithm is again risk stratifying the patient into either low risk, intermediate, or high risk categories. For the low risk category, there's a Class 1 recommendation for no testing. A coronary artery calcium or exercise ECG can also be considered in select cases to risk stratify. For intermediate to high risk patients, either anatomical or functional imaging can be done. Both have Class 1 recommendations. It's important to point out that exercise ECG is a step below here with a Class 2 recommendation in this case. If anatomical testing is done, you're looking to see if there's obstructive CAD. If there's obstructive CAD that is high risk, then it's a Class 1 to refer that patient for invasive coronary angiography. You also have the option of doing functional imaging or FFRCT for these patients and for the patients with non-obstructive stenoses. For patients that are referred for functional testing, you are looking for high-risk studies, i.e. moderate to severe ischemia. If they have moderate to severe ischemia, you're going to optimize their medication management and see how they do. If they do well, then your job's done. If not, then again, refer for invasive coronary angiography. Flipping the chart over now to patients with stable chest pain with known disease. Again, the first step is to look to see at what disease they have going into this. If they have known non-obstructive disease, then the first step is to intensify their medication regimen. If this is not successful, then the next step is to get either functional imaging or, you guessed it, FFRCT. Swinging to the other side of this algorithm, if the patient has known obstructive CAD, then we need to intensify their management right off the bat. If they have high-risk CAD or frequent angina, then you can refer for invasive coronary angiography. If they do not, you can get functional testing. Again, exercise ECG is a second-class option here, a Class 2A recommendation compared to the Class 1 garnered by stress CMR, stress PET, stress SPECT, or stress echo. And some key takeaway points from the stable algorithms. For intermediate to high-risk patients with stable chest pain without known CAD, cardiac CT is effective for the diagnosis of CAD, for risk stratification, and for guiding treatment decisions. For these patients, there's also a Class 1 recommendation for functional testing, including, which is new, stress CMR. They make a point of highlighting that PET is actually preferable over SPECT if it's available, as it improves diagnostic accuracy and decreases the rate of non-diagnostic test results. And finally, stress ECG has dropped to a Class 2A recommendation. Lastly, if you do either functional testing or anatomical imaging, and either one is not conclusive, then you can swap and do the alternative. The release of the guidelines were certainly not without controversy, and while the guidelines were supported by the Society of Cardiovascular Computed Tomography and the Society for Cardiovascular Magnetic Resonance, they were not supported by the American Society of Nuclear Cardiology. After the guidelines were released, the ESCentric issued a statement outlining why the society was not supportive of these guidelines, and I'll try to outline the summary of their major points of contention. Their first point of contention was that they felt that FFRCT was given an inappropriately large role in these guidelines. A major concern that many members of the ESCentric Board of Directors expressed was the oversized role given to FFRCT, especially given the limited availability, efficacy, level of adoption, and substantial costs. FFRCT was given a level of recommendation of 2A in 4 categories of patients with chest pain and appeared prominently in multiple flowcharts throughout the guideline document. FFRCT itself was initially introduced as a method to add functional information to the anatomical assessment of coronary stenosis on cardiac CT. The CT FFR values are actually calculated from computed coronary anatomy models. Trials like this have shown that FFRCT can improve the specificity of coronary CT. Douglas et al. Took 584 patients with new onset chest pain and prospectively assigned them to receive either usual testing or cardiac CT with FFRCT. And the primary endpoint was the percentage of those patients that went on to have an invasive coronary angiogram that showed no significant obstructive CAD. You can see that the regular testing arm had a significantly higher proportion of patients with a negative coronary angiogram at 73.3%, compared with only 12% in the FFRCT arm, yielding a risk difference of 61%. Still, it should be noted that FFRCT is not actually measured, but it's instead calculated from coronary anatomy. Its derivation is based on numerous physical assumptions and virtual calculation of hemodynamics across the coronary trees. So a high-resolution, patient-specific anatomic model is essential for FFRCT calculation. Patient motion during image acquisition and heavy coronary calcification can significantly decrease the image quality of cardiac CT. And recent trials have shown that FFRCT is actually not even available in up to 12% of patients, mainly due to patient motion and vascular calcification. Furthermore, there's a stepwise decreasing pattern of area under the curve for FFRCT as coronary calcification increases. And remember, patients with a heavier calcium burden are the exact patients where we do not want to be missing a functionally significant lesion. Furthermore, it's been argued that the overall diagnostic accuracy of FFRCT is still low. For example, when FFRCT was compared head-to-head to SPECT and PET in a post-hoc analysis of the Pacific trial, its diagnostic accuracy was similar to SPECT perfusion imaging on a per-patient analysis, and it was actually significantly lower than PET. In addition, the value of FFRCT for coronary lesions that are in the range of 40 to 70% remains disputed. The aim of this study that I've highlighted was to compare the incremental prognostic value of CT FFR versus that of ischemia detected on SPECT perfusion imaging on incident cardiovascular outcomes. They studied a retrospective cohort of 471 consecutive patients who underwent clinically indicated cardiac CT angiography and SPECT perfusion imaging. The primary outcome was all-cause mortality and non-fatal MI. On multivariate Cox proportional analysis, the presence of ischemia on perfusion imaging, but not FFRCT, significantly predicted death or MI with a hazard ratio of 2.3. Thus, in this study of high-risk patients after cardiac CT, FFRCT did not appear to offer as much incremental prognostic value as SPECT myocardial perfusion imaging did. There's also the issue of availability. Currently, only one company provides FFRCT, and it's not actually reimbursed by the Canadian healthcare payers. Myocardial perfusion imaging is dramatically more available and is much more familiar in Canada and the US. ESCentric felt that a greater emphasis was also needed for patient-first imaging. No one test is perfect for all patients. Thus, the decision about which test to order can be a nuanced one, and cardiac imaging tests tend to be complementary to each other. Very careful patient selection is needed, and physician and technical local expertise, availability, quality of local equipment, and patient preference are extremely important factors to consider. ESCentric felt that there was not enough emphasis on this important point, and it's hard to capture this concept in flowcharts in a diagram document. For them, this was a key and important limitation of the guideline. Next, ESCentric felt that greater emphasis should have been placed on the benefits of multimodality testing and risk scoring. While the AHA-ACC chest pain guideline mentions the concept of combining coronary calcium scoring with functional testing, ESCentric felt that there was inadequate discussion of the benefit of this approach, one that's actually growing in the nuclear cardiology community. ESCentric endorses the concept of multimodality imaging by combining myocardial perfusion scans with coronary artery calcium assessment. This combination has several advantages. It can identify which patients with normal myocardial perfusion scans have preclinical coronary artery disease that actually warrants aggressive risk factor modification and close clinical follow-up. The combination of perfusion imaging with coronary artery calcium assessment also improves the diagnostic accuracy and strengthens the prognostic power of perfusion imaging. Finally, ESCentric took issue with the fact that all stress testing modalities were lumped together in this guideline document. All stress imaging tests have their unique advantages and limitations, and therefore there are important differences in sensitivity and specificity and strengths and limitations between exercise ECG, stress echo, SPECT, PET perfusion imaging, and stress MRI. The concept of this dichotomy of functional testing versus anatomical testing is a common theme in the guideline in many patient groups, and this approach runs the risk of A, giving overemphasis to cardiac CT, and B, blurring the distinction between different types of functional tests. So after all of that, what do we take away from all of these guidelines? I'd like to finish the talk today by going through a pragmatic approach to image modality selection. Previously, following the Canadian guidelines, and essentially currently, this is how we approach image selection. For intermediate risk patients, if they're able to exercise and have a normal ECG, then they can get an exercise ECG stress test. If they're able to exercise and have an abnormal ECG, then they can get an exercise nuke, echo, or cardiac CT. And if they have a large BMI, then PET is recommended. If they have a low pretest probability, then cardiac CT is recommended in that case. Now, after all of the major guidelines updates, you can see from what I've highlighted here, it's quite clear that treadmill testing has kind of been downgraded or gotten the boot. And while exercise testing is on the outside looking in, cardiac CT is now definitively in. So this is potentially a major shift in the way that we think about risk stratification, which means that, this is maybe the new way to think about risk stratification if we choose to adopt these recommendations, and that's a big if. Low risk patients do not need testing, and if testing is done, we can do coronary artery calcium scores for risk stratification. For intermediate risk patients, if the pretest probability is on the lower side, a cardiac CT can be done. If the pretest probability is on the higher side, then functional testing can be done. Which functional test to do depends on several factors. If the patient's able to exercise, it depends on the patient's BMI, it depends on the patient's whether they have a normal resting ECG. Do I think that this is relevant or applicable in all of Canada? Certainly not. Access to advanced imaging modalities like PET or perfusion CMR in a country that has so much geographical variability is just not practical or pragmatic. I believe exercise ECG still does have an important role in CAD testing, depending on where you are in Canada. That being said, I think non-invasive testing is advancing and improving constantly, and therefore it's important for all of us to have a good foundational knowledge of the strengths and limitations of each modality. All right, so that concludes everything I wanted to touch on this morning. Ultimately, our job as physicians and as cardiologists is to choose the right test or treatment for our patients. And this is a field that's rapidly evolving and continues to develop. I'd like to say a special thanks to Dr. Chow for his assistance in preparing this round's presentation. And on that note, I'd like to thank you all for your time and attention. And at this point, I'd welcome any questions.